We are here today for our cohort coaching session 6. This is the Crisis Now mobile crisis outreach teams, and we are focusing on the crisis intervention timeline today with our speaker and presenter and gem of wisdom and knowledge, Jamie Seller. We are going to be going through real quickly our intro slides. First of all, this is our standard disclaimer. We are offering this training through the Crisis and Recovery Enhancement TA Center, which is the CARE TA Center. We are funded by the California Department of Healthcare Services and administered by the Center of Applied Research Solutions, CARS. The views and opinions and content expressed in this presentation do not necessarily reflect the views, opinions, and policies of the California Department of Healthcare Services, but we are extremely thankful for their support and their financial support that allows us to bring this knowledge to you. So what is CARE? We are the Crisis and Recovery Enhancement TA Center, and we provide a comprehensive array of training and technical assistance services to California's Mental Health Service Act funded stakeholders and partners. The goal is to strategically plan, effectively implement, and continually evaluate and improve the behavioral health coordination and crisis response services that all of you are providing. Our CARE TA Center team is made up of partners, including the Center for Applied Research Solutions, Recovery International, NAMI, the California chapter, C4 Innovations, also Impact Justice, and Stanford Sierra Youth and Families. And together, we are able to provide support through technical assistance and training that includes needs assessment, listening sessions. We have our annual conference, which is coming up on May 25th. I encourage you to log into our website and register for that because a little birdie told me there may be some perk if you're an early registrant. Like I mentioned, technical assistance and training. We also have a resource library on our website, which provides you access to evidence-based resources, and you can search through fields and find what you need that is particular to the subject area that you're looking into. We have a quarterly newsletter and our social media channels, which we will show you. We have a link to those at the end. And we also provide a 5 things need to know digest and cafecitos, which are small recordings of current events and topics that are important in the field that we all get to work in. As I mentioned, the topic that we have is Crisis Now mobile crisis outreach teams, with the focus today on the crisis intervention timeline. And as I mentioned, we have a dynamic contributor to the field, Jamie Seller, and he's going to be walking us through today's session. So I will go ahead and pass the mic over. Thank you so much, Jamie, for being here and doing this.
Yeah, I appreciate it. Certainly glad to be here, and thank you for that warm welcome. You know, I know a lot of I'm starting to be able to recognize a lot of the names in the chat boxes. So I make up that a lot of you have been here for one of these before. So I won't go too far into who I am, but my name is Jamie Seller. I'm the Chief Strategy Officer for RI International, which is really a beautiful title. But what it really means is that I have been doing consulting and training really for RI probably for about the past 6 years. Prior to that, I led the mobile teams in Maricopa County. We run 24 mobile teams a day. We've got teams that work with IDD, teams that work with vets, teams that work with children. And that was my life before I got recruited to come over to RI. So fortunately, I love crisis work. I love mobile street level crisis work. And then when SAMHSA had its guidelines, when SAMHSA was deciding it needed to put guidelines together for behavioral health crisis care, they came to RI, and I was fortunate enough to be one of the 14 writers on SAMHSA's national guidelines. And really where I started to put my time in was really around those mobile teams. So I'm very excited to be able to talk a little bit about it, but I'm not going to start to say that I'm the best expert in the country. You guys are running mobile teams out there. What I can say is that I'm someone who's sat in the chairs that a lot of you are sitting in. I've had successes, I've had failures, and really what the goal today is to really do some coaching and kind of think about it and use some of the experience that we've got, you know, in the chat to go ahead and support and make sure that the services we're providing are all going to be kind of up to snuff. So that's really who I am. 35 years. I'm a licensed professional counselor, clinician. Crisis is where I live and breathe. I like everything about that. So let's move forward and we'll jump into the agenda. This is what we're going to really talk about. We're going to talk a little bit about what SAMHSA says about the essential functions of the mobile crisis services. What should we be doing out in the field? What are our jobs? What are the check boxes we need to be checking off? We need to understand the need for a model of crisis intervention. I'm going to actually highlight a little bit Robert's 7-stage crisis intervention model. And we're going to talk a little bit about why that may work for you, why it may not work for you. And we talk about a dozen other crisis intervention modalities that you might need to have. Really what I'm going to do during that phase is just tell you, you need to get one. You know, models are a dime a dozen, but you need one. So you need to kind of figure one that's going to ring true to you. On some level, they're probably all fairly similar, but we're going to talk about the need for that. We're going to discuss how we integrate whatever model you decide into the SAMHSA elements. And then we're going to do just some final tips on intervention timelines from a seasoned professional. So this is hopefully what we get through today. And while I can be fairly verbose, I'll try to do it with enough time to ask Q&A at the end. So if we take a look here, I want to always go right back to SAMHSA. And really what we're talking about here, this is the what mobile teams do. This is what SAMHSA talks about it. It's the functions they serve. Every intervention that we do should have these elements built in. Just kind of run through. However, knowing that the components don't necessarily equate to success in the field. So just doing these things isn't going to make you successful. There has to be a common model that the team is working from that helps in its decision making. And I'm going to go over that more in the next slide, but really what I want to do here is plant a seed or two about these are the things that your team should be doing. And once again, I'll come back in a later slide to describe each one in detail.
So our first question is, how long is the average intake time for your mobile team?
That's going to be time on scene. And that's going to be, I've arrived on scene, not the 20 minutes to 2 hours to drive out there, but I've arrived on scene. I've made my first connection with the client that I'm serving to the time I'm getting back in the van or the Prius or whatever you're utilizing. Well, and I'm going to talk about this before you jump into a few of your other questions if I possibly can. So I don't think there's a right answer. I don't think there's a wrong answer, but I'll tell you how I tend to start to look at these things. I do a lot of consulting. I'm in a lot of communities looking at their mobile teams. And what I can say is I've seen a correlation between those 45-minute to 60-minute interventions and those interventions that are over 90 minutes and what it means for 60 to 75 and 75 to 90. So what I can tell you is, you know, two communities in the country have really been leaning into mobile teams over the last couple of decades. It's going to be the state of Georgia, which has mobile team coverage in all 159 counties, and then Arizona that has mobile teams across the state, but really specifically in Maricopa County. And we generally tend to run 75 to 90 minutes. So as I come into a new community and I start looking at mobile teams and I start thinking about these things that you see on your screen as far as what are the essential functions? What am I trying to do within that time frame? What I do know is that when 45 minutes to 60 minutes is in aggregate, my average amount of time on scene, that I'm probably not getting to everything that's on this list. What I am probably doing is doing a good level of care assessment, determining what the risk is, and then coming up with a plan to go ahead and get somebody to that next level of care. What I would equate it to a little bit more often is a level of care assessment. And teams that tend to do that have a focus for their mind on their mind that as they're going out, I need to determine where somebody's going. If we really talk about what the core function of a mobile team is, it's to do that, absolutely. But it's also when able and when possible to de-escalate, get resolution in the field, and allow somebody to be what we would call community stabilized, which is to remain in their placement, whether that's at home, whether that's at the shelter, whether that's at the group home, wherever that's going to be. The goal is to keep them out of those higher levels of care. And we do that through good assessment, making sure somebody's safe to stay in community, but then also providing those de-escalation and resolution services that we think are going to be absolutely paramount. Now, conversely, what we have seen in Maricopa County is there is a correlation between time on scene and community stabilization rates. But what I can tell you is that correlation doesn't really match much up after about 90 minutes. So if I see somebody for 60 minutes versus 90 minutes, what I will say is I'm probably going to get a better rate of keeping people in community. And we're just talking percentages, but it will start to go up minute by minute by minute. What I will say is what we've also seen is those interventions that last more than 90 minutes, maybe 2 hours, maybe 120 minutes, maybe 150 minutes. I don't get significant better results than I do in the first 90 minutes. So there is a point of a diminishing return that tends to come up. So in Maricopa County and in Georgia, the average intervention in aggregate, I take, Maricopa County, we do 2,100 interventions a month. If I take all 2,100 and I say this one's 40 minutes because they threw something at us on Jump Street, this one took about an hour and 45 minutes because we had some logistical family, when it comes back to it, between about 70 and 90, I feel is going to be that sweet spot where I'm going to maximize my ability to keep somebody in community, but yet I'm not at a point where I get diminished returns and I'm starting to stack cases up or clients up because I'm not able to get to everybody because I'm spending 2 hours out there. So once again, I'm not going to say there's a right or a wrong. I'm not going to come back to SAMHSA and say, SAMHSA says you should do it in 75 to 90 minutes because we never put that in there. Every intervention is going to be different. But I think that as you start working through a little bit more and you start looking at your data, you're going to start to realize I get different results with according to the different amount of time I am on scene. And at some point, I don't get any better results. That's just what I'm talking about here. Now let's go ahead and jump into, so I'll just touch basically, I think I talked about that. We'll jump in. So when we talk about having a model, really what I focus on with the models are going to be, once again, models are a dime a dozen, but you need one. I'll go back to what John Franklin Sierra, who works for the CEO office in their alternative crisis response and alternatives to incarceration programs, will say, and he's a PhD in systems. He's an engineer, and he says, look, all models are faulty. Some are useful. And I find that to be true. When I went through my master's program in counseling, they taught me 9 theories of personality. At the end, I said, okay, so which one's right? And basically I got looked at and said, well, which one do you kind of feel is right? And I think that's a lot about the intervention models. So as we start looking at intervention models, there's a lot of them that are out there. I mean, we can certainly talk about psychiatric, first aid or mental health first aid. We can talk about the ABCD model. We can talk about critical incident stress management, of which CISD is a component of that. SAFE or R, Nova Crisis Intervention. We can talk about the CIT trainings. We can talk about CPI, therapeutic options, just a host of things that go in there. And what I'm saying is I am not very concerned that you have to pick a particular model. What I am concerned that you pick a model. What I do think it's a little bit like Mexican food. You get your beans, you get your meat, you get your tortilla, you get your cheese, you get your salsa. It's just different ways to go ahead and wrap up, but really the same basics underneath it. And part of the reason that I do like having that model, and we'll talk about it a little bit later, is it helps me communicate with my team about what they're doing. And if I can communicate in a consistent manner with an underlying premise, I can get consistency in my mobile teams. Because there is nothing worse, this as you're running a team, and I've got a high performing team and a low performing team. And I'm not sure how to get my low performing team up to my high performing standards. Having a model across allows you to go ahead and make that push. But once again, I'm going to come back to this. This is the one that I utilized here in Maricopa County. The reason I utilized it, it was the model that was there when I got there. I just happened to like it. But when we start talking about the components or those elements that SAMHSA says, at the end, I'm going to align them up to this and show you just how well it matches up. And like I said, this has been around for 30 years at this point. So let's go ahead and jump into the next screen. Okay. So really what I'm doing is I'm going through the elements that we had talked about. Triage and screening is going to be, absolutely important. Should be the first thing that we do, kind of jumping out of Jump Street. Now, as most mobile crisis responses, they're initiated via a phone call or a hotline, or somebody other than the mobile team is actually starting to take that. So the information we generally tend to start with is gathered by somebody else. So the initial step when we are out there on scene is to determine quickly as possible what the level of risk is currently there. So all of us have been out on mobile teams where in the first 5 minutes, I need hospital or I need police or I need a paramedic to get out here because pills have already been taken. I can't start to do that on the back end of my, I might be too late. It needs to be done early to determine if I need to bring in other first responders, such as police or emergency services. So once again, in mobile teams, if I talk about everything, safety has got to be the primary focus initially. Safety and security. I've got to have my team safe. I've got to have the people I'm working with safe. Then I can go into advanced practices of assessment, determination, and processing and engagement, and all of those kind of things. I get reminded in this function of when I was in Boy Scouts or when I was leading Boy Scout troops. Basically, when you're teaching first aid, you learn the difference between a hurry event and a regular event. A hurry event means I got to do something absolutely right now. I don't have time to go through my entire checklist. I've got a high priority. And really, that triage screening is something that needs to happen. And we'll talk about it in relation to Robert's 7 stages, because they talk about this, and then they talk about developing rapport. And sometimes developing rapport helps you do a better job of this. But once again, this needs to get done. And remember, this isn't full assessment. I'm not going in depth about somebody's substance use disorder when I'm doing that triage and screening. I'm really making a determination. Are we safe to do the rest of my 75 to 90 minutes here? And I always want to encourage new staff that are coming into the field is your assessment is going to change over the course. That first initial, I'm assessing the situation, I may assess it high. And after I develop rapport, things may start to kind of stabilize a little bit. That's the goal. Or I may start in and I feel this person seems pretty compliant, pretty calm, everything looks pretty good. And after I ask them the first question about what's wrong, things start to escalate. I'm going to need to change that. So one of the challenges we have in mobile teams, and you got to do training for this, is that clinical impressions change over the course of the intervention. That's what the interventions are for. Hopefully they're changing in a positive direction, but they are going to change periodically in that negative direction. And if I am focused on my initial presentation of being the end all be all, that's it. It's not going to change. I'm going to miss so much, and I'm increasing liability for the agency and risk for the person that I'm serving. So this has to be done. So as you're thinking about the checklist, I'm going down of what we're doing. Understand that the first and foremost thing you do is going to be that triage and assessment, or triage and screening. Shouldn't take more than a few minutes, 5-10 minutes, but I really need to have a focus on that. So let's move on into assessment, which should be our second, consideration. Now, once again, these are the elements. And when we talk about the elements, what I will say is that most of them you're going to get to. It's a little bit like that old Elizabeth Kubler-Ross on Death and Dying. Everyone's going to go through DABDA, the denial, the anger, the bargaining, the depression, the acceptance in grief, but I can't guarantee what stage they're going to go through. So what I will say about a lot of these things is I know how they generally tend to flow, but I might do one first, I might do one second, I might do one third, and then I might do one first, and then one third, and then one second. I might change the order that they come through. So what we talk about when we're looking at SAMHSA, when we're talking about assessment, we need a behavioral health professional. And remember, in the SAMHSA model, every team has to have a licensed clinical professional there. You don't get Medi-Cal reimbursed if you don't. You don't have somebody that can do a lot of these things if you don't. We believe the second person on that team should be a paraprofessional, a peer support specialist when able, if not bachelor's level or case management, behavioral health tech, or behavioral health paraprofessional working in that. So when we're looking at SAMHSA guidelines and kind of putting them together, we know an assessment needs to be done. I do know that an assessment can't take 2.5 hours out in the field. And historically, as we're creating assessments for community-based work, we create something that we like, a new regulation comes in, and then I add something new in. I get a new clinical director and they add something new in. And pretty soon I've got a 15-page psychosocial assessment that I'm doing on scene, and that's going to take me an hour and 20 minutes. Can't have that. I need it to be fairly crisp and clean, but these are the things that we think you do absolutely need in there. So if you're cutting things out to go ahead and make it streamlined, make it more of an assessment versus an evaluation, something up from a screening, but something not up to that evaluation level, these are the things that you really want to have in. I want to have what my precipitating event is, what's causing that crisis event to happen. Really, the primary question is why now? Could have been in crisis a week ago, but you weren't, or maybe you were. You could have maybe called me tomorrow. What made today of all possible days the day that you called? I need to be able to identify that, because resolution of that often is going to be what stabilization means. I need to do safety and risk for the individual and others involved, including an explicit assessment of suicide risk. In my documentation, I have to have something that addresses my assessment of what their risk is for self-harm. What I'm going to recommend for you. And like I said, there's a lot of ways to go ahead and do this. The Columbia Suicide Severity Rating Scale is a quick down and dirty screener with a lot of evidence behind it. It's free, it's easy to use, and it's the most commonly used screener for suicide out there in the world. As such, if you utilize it, it increases your safety, decreases your liability tremendously. It's easy to go ahead and train to. There's a lot of work on it, a lot of research. I would recommend all of you have the CC or the CSSRS in your toolbox is one of the things you do. You can do it quickly. We need to do the strengths and resources of the person experiencing the crisis, as well as those family members and other natural supports. We need to do a history of specifically inpatient mental health or substance use disorder. Kind of what is their history around care been, what medications they're on, because there may be medications interaction they're going to need to be going on, and any medical histories that may relate to the crisis. So once again, as it may relate to the crisis. So understanding somebody has diabetes is helpful, because if their blood sugar starts to get out of whack, some of the behavior we may see as far as altered state of consciousness is going to start to creep in. So what I may be looking to do then is making a decision. This may be more medical related, in which case an emergency department or paramedics coming out to scene may be more appropriate than me trying to talk this person to go to an urgent care center, an inpatient psych hospital, for them to go ahead and turn around. So these are the things that absolutely need to be there if you want to be in compliance with SAMHSA. I'm not saying don't put anything else in there. You may want to go ahead and put in, but this would be the bare minimum of things that you would want to have in there. So let's go ahead and jump to the next screen. Here's the thing that I think most people tend to just kind of skip over. They're not thinking that part of their goal is to stabilizing community. So as we take a look through de-escalation and resolution on a very basic level, if I want to decrease the amount of folks going to emergency departments with behavioral health issues, decrease the amount of people being unnecessarily hospitalized, decrease the amount of people going to jail, I need to be very good at this. Once again, my element is not just do an assessment and refer, assess and refer. My goal should be stabilizing people in crisis. And what we're going to see, in the last slide, we'll really talk about the goal is to be able to resolve people's current crisis and support them in building the resiliency they need to not get into crisis in the future, which means I need to be doing a lot of processing. I need to be doing a lot of therapeutic work as opposed to just going out there, checking boxes on an assessment, coming up with a clinical impression, and then doing transport or arranging care someplace else. So how you end up doing your de-escalation, your resolution is going to be dependent on the model that you choose. And once again, you want a model, because if I've got a model, then my teams are at least acting similarly. And if things are acting similarly, I can then start to fine tune. If everybody's doing something absolutely different, I don't have anchors to get everybody moving in the right direction, because how I get team 1 to work better is different than team 2 or team 3 or team 4. I'm continually herding cats. I've got to have that model. And how you use your model is what your de-escalation is going to be. But what I will say is to get resolution and de-escalation, some universal truths I've seen, regardless of what model you're going to use, is it doesn't happen without a therapeutic alliance. If I am working with somebody and I do not have rapport built up with them, if there is no trust, my likelihood of getting them to a positive outcome, it's not involving involuntary commitment or them refusing, whatever aftercare recommendations I'm making, those numbers go down really low. And what I can say is if I can develop rapport, I feel fairly confident I'm going to be able to support somebody into getting into their long-term recovery, even if the next step for them is an inpatient hospital, inpatient locked hospital, outpatient, whatever that one's going to be. It only happens when your team is able to allow people to reframe their experience. So once again, precipitating event when we talk about assessments, what made today the day of all days? I broke up with my girlfriend 45 minutes ago. Now I know my anchor is how they're viewing that particular breakup. If I can't help them reframe that particular experience as to something less catastrophic, I'm going to have a hard time supporting them and getting to the next level. And at the end of 90 minutes, I'm going to say, can't do it, going to go ahead and take them to a facility. So it does really come back to reframing. And once again, it only happens when hope reappears, when people can see that there is a light at the end of the tunnel and that their crisis is temporary as opposed to permanent. We're going to talk a little bit about peer support. And quite frankly, I think peer support is really where we start to lean into helping people find hope. Now, I do want to say these skills can be learned. And I do want to say that some staff are just naturally better at this. So as you guys that run mobile teams, or you have mobile teams, or you're on mobile teams, or you've worked inpatient facilities, you know the difference between strong staff and weak staff. I can't describe the difference between a strong staff and a weak staff, but you can feel it, you know it. I'm going to be more than happy to go ahead and work with particular staff because I know it's going to be a smooth shift. We're going to get a lot of positive things done. We're going to change some lives. Or I'm coming in and I'm like, this is just going to be pulling teeth the entire day. But I will tell you the difference between strong staff and weak staff is that ability to do those universal truths, develop rapport, supply hope, help somebody reframe their existence or their experience. It doesn't necessarily have to do with they do really good diagnostic work, or man, they have great documentation, which is absolutely important. But once again, that's not what I would define as strong staff. These are the important things. Let's go ahead and jump in. Peer support. So once again, SAMHSA does recommend if you can get a peer on a team, it's great. You know, the clinician can take care of the heavy lifting and the stuff that's going to require legality. You know, I've got to be able to be a peer, or I've got to be able to be a clinician in order to create a treatment plan that may get me paid for Medicaid or Medi-Cal. I need to go ahead and put some kind of diagnostic criteria in there. I need to do an assessment, and I have to be the one that signs off the assessment. I'm a licensed professional counselor. I understand my role. But once again, the primary intervention that you're going to run into with staff or with in crisis work is going to be that engagement. How well did I engage that person? The better I did, the better outcomes I'm going to go ahead and get. So peer support is a SAMHSA-defined evidence-based practice. It wasn't 20 years ago. It is now. So having peers on your team is an extra evidence-based practice for you to go ahead and have in your toolbox. What I will say, it's the best way to instill hope that recovery is possible. There is nothing stronger, nothing as a clinician I can say that is as hopeful. And I can find words often, but I can't find words more hopeful than when I was in crisis 3 years ago and a mobile team came out to see me and I thought everything was over. Here's what I did. Here's how I got back. And here's where I'm doing now. That is living proof that recovery is possible. Everything I say can be worded very well, but it may not get to that deep root. And it's often stronger opportunity to engagement. What I mean by that is, if my recommendation is we think that outpatient is going to be a support for you, I don't think we need to take you to the hospital. I'm going to take you to ABC counseling. It's really strong for someone to say, look, I've gotten help at ABC counseling, or I've got a lot of friends that have been to ABC counseling. We've got good results through ABC counseling. I think you're going to like them. The term I would look at that point is leveraging goodwill. So if that peer has created a good experience, has developed rapport, developed trust, and then that peer recommends the next level of care, all that goodwill that peer has created, or the clinician, then gets transferred onto the agency, which increases that likelihood that they're going to follow up and make that appointment. Nothing more frustrating in the world, and you have a great intervention, come up with a beautiful treatment plan, beautiful plan for safety, and they just don't follow through on it. So we gotta really leverage that goodwill. That's the next step that we do in crisis work. I got 75 minutes to 90 minutes to change a life. I've got to do it fast, but I've got to do it tight. Peers are going to help that. Once again, their goal isn't to check the boxes on the assessment. It's not to make the diagnosis. It's not to do any of that. It's to engage and help people reframe that experience into a way that helps them be a little bit more supportive. Let's jump into the next one. It's an essential function is coordination with medical and behavioral health services. I didn't know what to go ahead and write and kind of think a little bit about this. But once again, obviously your interventions are not the end all be all. I would be remiss to say that in a 75 to a 90-minute intervention that you are going to go ahead and be able to significantly change someone's life, that they don't need the next level of care to support them. You know, if you can find the words to go ahead and do that, we'll have you going ahead out on the lecture circuit. We'll all be millionaires if a 90-minute intervention is going to go ahead and be long lasting. Really what we're doing is helping people get to that next level of care. So we need to be able to coordinate with medical and behavioral health services. We need to go ahead and have a plan for somebody post-discharge, support them in getting connected. And one of the basic tenets or values that mobile teams have to have is that the community is strong enough to support this person to get better. If they don't, if I don't believe that, I'm going to have some issues. Once again, frequently when I interview mobile team members in new communities and ask them what their role is and what they're supposed to do, this is what they lean on. I'm supposed to determine where people go and get them connected to outpatient, or get them connected to services. So I can't. That's part of it. Obviously, I've got to do that. But there's a lot of folks that believe that either the assessment is their only role, or the connection is their only role, and they're missing everything. They're missing everything else. It's a component of the entire system. Let's jump into the next one. So crisis planning and follow-up obviously is important. As I had kind of mentioned a little bit earlier, one of the goals is to help stabilize people in this current community or in their current crisis. But then I want to make sure they are able to be supportive and not go into their next crisis as well. So really what I kind of start to focus on this is, if I had one element to go ahead and do that encapsulates a lot of the other ones, it's going to be this. If I am doing good crisis planning and follow-up, I'm utilizing a lot of skills that I do in the other areas. I think it's often missed. I think a lot of teams, as I talk to them, they're not looking at doing standard safety planning. They're not looking at doing crisis planning. They're not looking at how I can support this person from getting into the next crisis or out of the next crisis. I would recommend that you guys use some kind of safety planning. I would recommend Stanley Brown. It is used nationally in our facilities in Australia. We actually will utilize it as well over what Australia typically utilizes. Arguably, I think this is the most important aspect because it does incorporate an awful lot of the other services. It actually gives me screening opportunity. It is a great opportunity to go ahead and provide support, particularly peer support. It allows me to coordinate on what the next level of care is going to go ahead and be. And really, as people start to go through that, they start to see that there's hope, that they can get through this, that there's a pathway for them forward, and it's going to improve their stabilization. So I really look at this part as being maybe one of the most important because it has so many elements coming through. Now, what I will say on the Stanley Brown safety planning tool, easy to utilize, not difficult. Currently, they want you to be a clinician to go ahead and operate it. As RI was running through it, and we've been utilizing it for years, we realized it's not that technical. It's not that difficult. We think peers can do it. So we're actually piloting with Barbara Stanley of Stanley Brown for this use in peers, where we're utilizing it in our facilities and seeing what results that we get, because we do believe that peers should be able to utilize this in the system as well. And we do believe that it's going to be strong to be able to utilize this as mobile teams because I want to get my peers involved as much as possible. So the two things I am going to say, look, I'm going to fully strongly recommend. You can come up with any model you want to go ahead and utilize. But as we're thinking about it, I would say use the Columbia screener always. Go ahead and utilize the Stanley Brown, always. Everything else, half one dozen of the other, you can go ahead and start to think a little bit about it. Let's go ahead and jump to the next one. Okay. Give me just a second. I think I've got here we go. So we're talking about this. So as we look through here, what I want to do is I want to say, look, remember, all models are flawed. Some are useful. All models are flawed. Some are useful. Models are a dime a dozen, but you need one. So the reason I use Robert's 7 stage, and once again, it was what I was using when I first started coming up. I think it's effective. I kind of like it. But if I actually transpose this over those essential practices or essential services of a mobile team, and I take a look at one, level 1 at the bottom there, that's really triage and screening. Part 2, that's really peer support. Number 3, that's really my assessment. Number 4, that's really part of peer support. That's kind of what peer support does. Number 5, that's my de-escalation. That's my stabilization. Number 6, that's going to be my crisis planning and follow-up. And number 7 really is my coordination with medical and other behavioral health. So I can sit there and really kind of talk about, well, I can plug in SAMHSA's guidelines to this. So if this is a crisis intervention model that you want to utilize, I fully suggest go ahead and jump into it. The other thing that I want to talk about from this is, and we'll jump into the next one because I'm going to bring it up in the timeline and tips. I'm going to jump around a little. I'm going to start from the top here. So tips that I really have about the crisis intervention timeline is, one is, what metrics do I want to look at? What I will say is, if you start doing some digging in, you're going to realize shorter interventions tend to have higher levels of going to a higher level of care, or increased levels of going to higher level of care. And obviously on some issues, that's It's the time on scene that's going to be important. So obviously, if I've got a 20-minute intervention, I might have gotten out there. The guy threatened to kill myself, started waving a knife around. We went ahead and backed up and immediately knew a 5150 was appropriate. I don't need to spend 90 minutes to do anything with that. I'm not getting to I'm not getting to an outcome that doesn't involve paperwork. So 20-minute intervention is absolutely appropriate. I have assessed the situation. I have realized de-escalation and stabilization is probably not possible. And any additional time out there is going to be decreasing or is going to be delaying the actual care this person needs. So obviously it makes sense. But what you will see in aggregate is as you have your teams out there, your teams that are often out there 45 minutes to 60, 65, 70 minutes are not going to have as good outcomes as those that are staying a little bit longer. So I'm going to look at my time on scene. I'm going to relate that to what my community stabilization rates are and what my involuntary rates are. And I'm going to compare team to team to team. So definitely something to think about. What we end up doing, or what I ended up doing an awful lot, is once again, I've got strong staff and weak staff. And like I said, I don't have a checklist that's going to tell you strong staff and weak staff. You know it when you see it. I want my strong staff training my weak staff. I want them to be the exemplars. If I need to develop rapport, I want them to show how to develop rapport. If it's helping people reframe their experience, I want them to see it from people that can actually do it as opposed to it being a theoretical concept. So your best staff you want to keep, and you do that by identifying them as being the best staff, allowing them to do what they do every day, and then giving them a little bit of added extra responsibility, accountability, or attention that they know what they're doing. Do that often. The reason I do like a model is it does help me with my supervision, and I want them to start utilizing language. So if I'm using, Robert's 7 stages, I'm going to ask questions. I do more coaching than I do, supervision of here's the information you need to know. But I'm going to say, okay, I know you had a difficult time with Jamie out in the field. How did you establish rapport with that client? Well, we didn't. Okay, tell me what you tried. What worked, what didn't work? What didn't you try that maybe you could have, would have, should have? What did you learn during your active listening portion? What kind of came out as you spent that time just listening as opposed to talking? Who did they identify as whom they can ask during the safety planning? Who's their anchor? Who do they connect to? Who's their natural support? These are ways that I start to bake in what they should be doing time in, because ultimately I want them to provide consistent interventions across my teams and across themselves. I want that fourth assessment they do in a day or that third intervention they do a day to look the same as the first. I want it to be the last intervention of the week to feel as strong as the first intervention. And when I have these models, it tends to work. And I want to ensure that every team member can identify what their primary role is. I often do this. If you ever call me to come out and evaluate your mobile teams, happy to go ahead and do it. I'm going to get your team members along. I'm going to say, what is your primary role? What is your goal for this particular intervention? And I guarantee if you've got 10 team members I meet with, I'm going to get 6 to 7 different answers. That's obviously a problem. If we want to go ahead and be the best, it means we need to be consistently doing things in a similar way to get to those outcomes. I'm not going to get optimal performances if people are doing it in 5 different ways. 1 may be optimal, 5 have to be suboptimal just by definition. So these are just some of the tips. Andy, I think that's it. We're up to Q&A.
Yes, so at this point, we'll go ahead and open it up for questions and discussion. And as you were speaking, I was curious also if anybody has any familiarity or experience with working through this model, or if they have a model that they've identified. That might be one thing that we get to do during discussion since we do have some time. But I'm going to open it up. Also, you are the one that everybody wants access to. So questions for you, I think, are a priority.
But also, I know a lot of us have been on these for the last 6 weeks. So questions may have been asked 2 weeks ago that
True.
normally today.
I wanted to ask a clarifying question also. I thought it was fascinating that you talked about the Stanley Brown model and that they're piloting a Barbara Stanley for peer use.
Yeah.
So I was curious if you could share a little bit more about what that peer use model is. If there's anything else you wanted to share about that.
Yeah, so I mean, the Stanley Brown, safety planning, it's a module. It's there's training around it. It's a safety plan. It's not fairly complex. It's actually fairly straightforward. 10 or 15 minutes of experience with it, you probably can go ahead and do it. But I think it's very important, and I think it's very powerful because the things that it starts to tie you to the guest or the client, allows them to start formulating how they are going to be able to support themselves. So it moves the locus of control from external a little bit more internal. Like I said, it does do screening. It does help build resilience. There's a lot that goes into it. But if you take a look through it, there's nothing in there that we have ever felt required a licensed clinician. I don't need to go through 6 years of, 4 years of undergrad, 2 years of graduate. I don't need to be a nurse. I don't need to be a social worker to go ahead and be able to deliver it. It's a very empowering but engaging tool. And once again, our belief, our peers are actually engagement specialists. The only role we look for them to be is to be engaging. So then what we ended up doing is we had conversations with Barbara Stanley. As you guys know, RI is kind of at the national front of a lot of these things. We're trying to push the crisis space forward a little bit. And we had a conversation. We're like, hey, why can't peers use this? And really kind of one of the responses we got back is, well, we never tested it utilizing peers, right? So I can't say it's an evidence-based practice for peers to utilize because there's no research on that. And we said, well, we got people in crisis. We got peers. We got oversight. We can ensure safety and security while we're doing all these things. Can we start to do that? So our chief medical officer, who works often with Dr. Stanley, went ahead and came up with all of the research protocols that you need to do. I'm a clinician. I have no idea what the research technically is. And Barbara said, look, if we can go ahead and utilize your sites, your peers, we can come up with the protocols that we need to go ahead and move this into something that could be considered evidence-based practice, but we need to do the research. So RI is currently doing that research. It's probably going to take 6 months to a year from here on out to go ahead and get that back. And then what we would end up doing is if that is the case, and once it gets published, we would start utilizing it in our facilities and our places that we are doing community-based work. Just to go ahead and make it a little bit safer for other mobile teams to start utilizing it with their peers. But once again, as you guys look through, it would be really, you need some kind of safety plan. It's the one to use. I love it.
Thank you. And you do have a question, two points in the chat. One question, Karen Lovato was asking, do programs use wellness recovery action planning for crisis planning follow-up?
We do. So RAP planning is evidence-based, lovely program, great to go ahead and utilize with folks. We utilize it in some of our longer-term programs, like respite levels of care, some of our residential programming. The reality is that it can take time. It's not fast, particularly fast. So we haven't used it in mobile teams just because of the time that it takes. I think it's a very good thing to go ahead and do on a follow-up, or if you've got a community like a peer navigator or some kind of community bridger peer navigation program out there. I think it's really important to be able to utilize that. We're strong proponents of RAP. Most of our peers are trained in it, but I think the challenge comes when you're doing crisis work and you've got calls starting to stack up. I probably need to be moving a little bit quicker. And in our programs that are 23 hours, we may not have the manpower to actually do it. So a lot of faith, love RAP. Practically, it becomes difficult, a little bit more difficult in some of the crisis work that we've done.
The other that we have is a peer support specialist is joining us. This is Karen Oath, and I just want to acknowledge that you're feeling supported by your supervisors, and that's why I was asking to hear what it is that makes you feel that way so that others can kind of hear. And so you added in chat, you're welcome to also turn your mic on and opine that way as well.
Well, we just have a really awesome team, all the way from the program manager down, well, I hate to level everybody, but down to me and my coworker. It's a very supportive team. They have confidence in our abilities as peers to engage with people in crisis. And And also, most of the time we're dealing with the hospitals, but from time to time we're out there, at least until COVID's over. So, they kind of take the lead and then we step in and then, so it's pretty cool. It's just a really great team,
Yeah. It is so affirming when your supervisors that they have confidence in you. So
yeah, they
that's so great to
see
hear.
our value. So
Yeah.
I think that's the most important thing, is that they see our value.
Yeah, that's awesome. Thank you for sharing and being willing to share. Any last minute questions? There's so much information, Jamie, that you share with us every time. And I get to sit here and I get to read and hear. And I just keep thinking, I can't wait till the recording comes out so I could do it again, so I could process more, because it's so much. And I just really appreciate everything that you're sharing in these spaces and the way that you do it. Thank you. And I will go ahead and close us out today. Thank you for being here. We look forward to being in touch with you. You can follow us on social media, through our website, and also sign up for our newsletter to continue to receive information about upcoming events and what we're doing. Thank you all for being here today. We appreciate you.